Hi students. So today again I am here with the second topic of the day, a very popular topic, patellofemoral pain syndrome. Since I am touching the topics of the knee joint and the knee pain, so I thought it will be beneficial for us if we can discuss another condition of knee pain which is very common among the population, and it is called the patellofemoral pain syndrome. Now this patellofemoral pain syndrome is a broad term actually which describes the anterior knee pain, and since the name suggests patellofemoral, we can understand that it involves the structure called patella and the bone of the thigh called femur. And we know the patella is in between the femur and the tibia in the knee joint. So let us see what in details what is the patellofemoral pain syndrome. And in the last of the video I will try to demonstrate some of basic exercises or stretches in order to manage or tackle this syndrome. So patellofemoral pain syndrome, also known as aka pre-patellar pain syndrome, chondromalacia, but chondromalacia we cannot say directly it is a patellofemoral pain because it is a pain in the patellofemoral, but it has a definite pathology where the inside of the patella, the undersurface of the patella, the articular cartilage, it gets softened and it gets eroded and pain starts. So that is, we will discuss that is chondromalacia. Then patellofemoral stress syndrome, patellar tracking dysfunction, runner's knee, lateral facet compression syndrome. So all these are interchangeably used, and but we will not suggest to use the chondromalacia as I said. But yes, other things like the prepatellar pain syndrome, the patellofemoral stress syndrome, patellar tracking dysfunction, runner's knee, lateral facet compression syndrome. These are the anonymous terms also known as we use for patellofemoral pain. We have an international patellofemoral study group, and they also gave some points, but not specific definition, but yes, some points which define the patellofemoral pain as: number one, it is the anterior knee pain; number two, patellofemoral pain syndrome used when no identifiable cause of pain; chondromalacia patella, that is softening of the patellar cartilage as I said; luxation, subluxation, complete or partial displacement from the trochlear groove; incongruence, that is lacking of fit of the patella; excessive lateral stress syndrome, or abnormally tight lateral retinaculum causing lateral tilt and high stress on the lateral patella. Jenny McConnell described the patella as a balance beam that adjusts the length, the direction and force of each of its arms, that is the quadriceps tendon and the patellar tendon, at different degrees of flexion. Now if you see this diagram, just understand this is the thigh, this is the shin bone, the leg, the quadriceps muscle, patella, the shin bone tibia, the fibula, and you can see in the diagram there are 4 arrows up, 2 on the lateral and the medial, and then you have the lower force. Now it describes as a balance beam that adjusts the length and direction of force of each of his arms, that is the quadriceps muscle when it forms the quadriceps tendon, and in between is the patella. The patella is a sesamoid bone that floats over this joint, and that is within this patellar tendon, and then it runs down as the quadriceps tendon, and then it runs down as a patellar tendon and inserts into the tibial tuberosity here. So if we remove this, if we take out this, then you can see inside the patella is attached to this tendon, and it sits or floats over the joint. There is a groove in the femur bone, and that particular groove accommodates the patella perfectly in proper alignment whenever there is flexion, extension, or whenever we do other activities as walking, running, squatting, jumping, all those activities. The patella is in a proper alignment, in a proper tracking, and that tracking happens when the patella and the grooves is in congruent position. So here you can see the medial patellar retinaculum, the lateral patellar retinaculum, the vastus lateralis muscle in the lateral side, this is fibula, the vastus medialis, the rectus femoris superior side, and this medialis is called the VMO, which is the muscle which balances the patella in proper position, the VMO. So this is the anatomical structures, how the patella works, and how each of the arm of the patella, that is the quadriceps tendon and the patellar tendon, the force is divided. It adjusts, the patella adjusts the length, direction, and the force at different degrees of flexion. Now if you see at 10 to 20 degrees of knee flexion, the inferior patella comes in contact with the lateral femur, which is highly unstable. In this 10 to 20 degrees of flexion, the patella is highly unstable and it is come in contact with the lateral side of the femur. When the knee is fully extended, full extension, patella sits lateral to the groove. Patella sits lateral to the groove. In 30 to 90 degree of flexion, that increases the contact with the groove, with the patella, and that indicates more stability. So 30 to 90 degree of flexion, you can say, is the most stable angle where the patella and this groove comes into contact. Then the medial patellar facet contacts with the patellar groove at 135 degree of full flexion. At 135 degree of full flexion, the medial patellar facet contacts with the groove. Also, there is the patellofemoral joint reaction force, which is responsible because there is an equal and opposite reaction to the resultant of quadriceps and patellar tendon tension. The quadriceps muscle tension and the patellar tendon tension, there is an equal and opposite joint reaction force. Now this force increases with flexion. When we walk, while walking, it increases by 0.5 into the body weight. While climbing upstairs, 3 to 4 times of the body weight, squatting 7 to 8 times, and in jumping you can see 20 times of the body weight. Next we come to the etiology of pain. The pain is mechanical in origin. Also the chemical substance P increases sensitivity of pain receptors, and these are found more in the retinaculums, in the synovium, in the fat pad, which ultimately altogether causes the inflammatory cascade. Now there already have discussed in the diagram the soft tissue stabilizers of the patella. So if you see the patella in the middle, as I said, in the superior there will be the rectus femoris and vastus intermedius forces pulling up. You can see medial forces like the vastus medialis obliquus, the VMO, which is responsible for the medial pull and the medial retinaculum. Then you have the downward forces, the inferior forces of the patellar tendon, and we have the lateral forces of the vastus lateralis, the ITB, iliotibial band tract, or the iliotibial band, which is continued from the hip, okay, and the lateral retinaculum. So altogether patella is balancing, or the patella is working against all these 4 type of forces. So what are the risk factors? If you see the risk factors that will precipitate this condition, first is the overload and overuse, which is mainly seen in the sports personnel or the overactive personnel, active athletes, especially females. Why especially females? I will discuss in details. And then overload and overuse is one of the prime factors. Then also studies indicate that there is altered VMO to the vastus medialis obliquus to the vastus lateralis response time. VMO is fired earlier than the VL in the control group. In the studies they have found it creates early activation of the medial force vector. Then functional testing shows that the patellofemoral pain syndrome patients with lower strength capacity, measured by vertical jump, anterior medial lunges, step down, balance, reach, single leg press, all this we can see the functional testing, and it shows that the patients with this syndrome has a lower strength capacity. The general ligament laxity also determines, and it causes increased total patellar mobility. Now one of the important factors is the Q angle. Q angle is the alignment of the knee joint. If there is an increase in Q angle, it will tend for patellar subluxation. That is, increased Q angle, increased lateral patellofemoral contact, pressure is increased and risk of patellar location is increased. Decreased Q angle means medial tibofemoral contact and pressure is created by the varus force. So if you quickly revise, what is the Q angle? The Q angle is the angle between the quadriceps tendon and the patellar tendon. It is the angle between the quadriceps tendon and the patellar tendon. Now how do we measure this? Quickly we brush our basics. The Q angle is formed in the frontal plane by 2 line segments. The first line is drawn from the anterior superior iliac spine ASIS to the center of the patella. Second line is drawn from the center of the patella to the tibial tubercle. Or first line we draw from the ASIS to the center of the patella, second line from the tibial tubercle to the center of patella, where they both intersect and form an angle. So in extension, this angle is around 14 degree in males and 17 degree in females, and in flexion it is almost 8 degree in both the genders. So if the Q angle is increased, there is greater chance of patellar subluxation. The next factor is the wider pelvis that is seen in case of females. That is why I told you before that in the females are more prone, because when we say it is patellofemoral pain, we should not think only about the localized knee joint or the patellofemoral. Why this patellofemoral pain arises, why the patella is not in track, or why the patella is in maltracking, not in alignment, we should think out of the box. We should think with the proximal and the distal joints. The superior is the hip joint, the lower is the ankle joint, and the structures in the hip joint, the pelvis, the hip joint, the muscles coming from there. If the muscles are tight or weak, or there is a rotation in the pelvis, this will affect the Q angle. or the patellofemoral, the patella will not be in the track, because if the quadriceps is tight, if the hamstrings is tight, if there is a weak VMO, if the ITB, the iliotibial band is tight, what will happen? The tight iliotibial band will try to pull the quadriceps, pull the patella towards lateral side. That is, it is not in congruence with the groove of the femur. If the VMO is weak, the patella will go easily towards the lateral side. If the pelvis is rotated, if the hamstrings are tight, then also because of the hamstrings tight or because of the quadriceps weakness, there will be the maltracking of the patella. Also, if you go down to the ankle, if there is pes cavus or there is flat foot, or the arches are not proper, or the calf muscles are tight, the gastrocnemius is tight, the same biomechanical alteration will be there, taking the patella out of the track, creating this kind of patellofemoral pain. So, wide pelvis, foot abnormalities study identified that cavus foot as producing increased forces on the patellofemoral joint with running. Gastrocnemius tightness limits dorsiflexion. If the calf muscle, the gastrocnemius is tight, you cannot go for dorsiflexion. That will cause more subtalar pronation, which in turn will increase the Q angle, and that will again tend the patella to go out of the track. So if the hamstrings are tight, the PF joint forces are increased by slight knee flexion, or more quadricep forces are needed to overcome the hamstring resistance. The ITB, as I said, if it is tight, it increases lateral force vector. Now, if the abductors and external rotators are weak, which are found in this group, they will go for weakness. The VMO goes for weakness, and the ITB go for tightness. That VMO, which is going for weakness, is decreasing the time of contraction compared to the VL. So all these factors we have to consider in the examination part of these certain kind of patients who are having this kind of patellofemoral syndrome. Now this kind of patient will give a history of diffuse anterior pain, swelling sensation, pain with steps, giving out due to quadriceps inhibition, theatre or movie sign positive, that is pain with prolonged sitting, and crepitus or popping sensation. So again I repeat, the history will be diffuse anterior pain, the swelling sensation, pain with steppings, giving out feeling due to the quadriceps inhibition, the movie sign or the prolonged sittings, pain positive, crepitus, popping sensation. Usually pain will be more while climbing up and specifically more while climbing down the stairs. So the complete physical examination of the knee is required with palpation, the hip to be examined, the foot, the flexibility of the muscles of the hip and the knee joint. Trendelenburg test should be tested positive or negative. The patella should be tested for gliding, patella gliding test, the Clark test, the compression test. Now the treatment or the management, basically to deal with the pain we go for the ice, the non-steroidal anti-inflammatory drugs. After that, once the pain subsides, we go for the stretching and the strengthening of the muscles, stretching of the tight muscles, strengthening of the weak muscles. Open and closed kinetic chain exercises are found to be very effective in studies. We can go for bracing, taping techniques, and also orthosis for the overall management of this condition. So I hope that we have got an idea to understand this condition, patellofemoral syndrome, and how the maltracking or malalignment of the patella will usually leads to this condition when the patella does not sit on the groove of the femur, when it is either laterally or medially pulled. Then there is friction in the parts. The inside part of the patella goes for erosion. Then in the long run it goes for arthritic changes. The cartilage is shredded off, and both the bones parts, when they rub, the free nerve endings are there, so the pain is the symptom. So we have to correct the root cause from the hip or the ankle, concentrate on the knee joint, and then bring the patella into the correct tracking or align the patella on the groove. And I'm sure with this we can correct the condition. And also at the end of the video, or in the second part of the video, I'm going to demonstrate few 4 to 5 exercises to minimize this kind of pain and condition, and to how to deal with this condition. Okay, thank you so much for watching, and any doubts, any suggestions, any comments, please feel free to give in my YouTube video link, which I am also going to share in the Google Classroom and WhatsApp groups. Till then, okay, bye.